thank you very much, Alan. You've actually made the job very easy. I'm going to go. And I'm a great fan of Cris Cancer. I love Cris Cancer. I think the charity is inspired. And I'll try and explain a little bit about why I think that. I'm quite a newcomer to Cris funding. But I feel that we're now in the era of preventing cancer. And I think Alan has set the stage beautifully. I think we're starting to realize, in answer to also another bit of your immunotherapy question, is that you should go earlier and earlier with immunotherapy, because that struggle between your immune system and your developing cancer happens very early on. So maybe we're giving immunotherapy too late. We should be going in earlier with immunotherapy. So to be able to understand all of this, we need to be able to test preventing cancer, which sounds like an obvious thing to do, but I'm not talking about really boring 10,000 patients taking aspirin and just seeing how they do over 20, 30 years. I'm talking about going into a very specific high-risk group of people who are genetically at risk of cancer, or for other reasons, environmental exposure, for example, to tobacco, or exposure to asbestos, or whatever the particular risk factor is, and focusing our work on this very high-risk group. In the past, they were practically excluded from studies because their risks were so high. But we want to sort of turn it on its head and learn from this high-risk group and gradually over time extrapolate out to lower and lower risk people ending up at the general population. So that's where we're going. And these studies, we're proud, we started this in Oxford. So Oxford's the UK's first centre to specialise in these trials. So we run them in a small population. We try and match to an intervention. So it's not just an aspirin prevention or something like that, which can take a very long time, and it's not a very new drug. We want to use new drugs in this setting. We want to be quite brave. There is a strong scientific component. So the participants in the study will have blood tests, and we'll be monitoring them over time, because it's remarkable that we still don't understand how cancer starts. I find that stunning. So normal cells go through this phase before they become cancerous, and that phase can take decades, and yet we know so little about that. And oncologists like myself and Alan, we've been trained to learn and work on an established cancer, but not to step back and think, okay, let's go back a decade. What's actually going on when that cancer forms? And that's what we really, really need to answer if we want to get anywhere. And then the idea behind these studies is we then ask a question, does this vaccine work? Does this medicine work? And then we hand that study over then to run a vast population-based phase 3 trials. But we've de-risked it in the process with our small studies. And hopefully at the end, the high-risk group will also benefit, because we'll have enough evidence to actually use an intervention in the people who need it most. So the three main questions that we ask is, in a precision prevention trial, does the intervention prevent or delay cancer? How does it do that? And what are the molecular events leading to cancer? We've got our first study going on at the moment. We're trying metformin, which is a diabetic drug, in patients with something called Li-Fraumeni syndrome, and their risk of cancer is 100%. It's just absolutely horrific. There are two spikes, one in childhood, around about the age of 6, and then another spike at the age of 30. And they have been excluded from every study in the past because their risk is too high. This is exactly the sort of group we need to work on. We need to do something about it. But then when we think about other cancers, when we think about the cancers that we all hear about, it is shocking to realize how long they're in our bodies before you actually get symptoms. So cervical cancer, this is a rather ugly artist's impression of a cervix. We have cervical screening, but we're not told it takes 5 to 10 years for those cancers to form. Colorectal cancer, 5 to 15 years, even longer perhaps. Some people even say 30 years. So if you think of the sudden surge in cases we've been reading about today in young people under the age of 40 getting colorectal cancer, those cancers may have been in their body in a pre-cancerous state for 20 years. So then you're thinking, we'd have to think, what food were they given as teenagers? We have to sort of really understand when it started to really understand what precipitated it. The good thing about cervical and colorectal cancer is you can actually go in with a scope and actually see the precancers. You can scrape off the precancerous cells in the cervix, and that's why cervical screening is also curative, preventative. And colorectal cancer, you can remove adenomas or little polyps. But what about our internal organs? Like, for example, the ovary. 4 to 6 years it takes to develop ovarian cancer. It's invisible at that point. No scans, no blood tests will tell you you are brewing that cancer. And that's something that my lab is working on at the moment. Equally, lung cancer, 8 years. So this is what I think we need to really focus our resources on, understanding what we call tumorigenesis, how cancers start. And Alan has summarized the immune system. So there is a breach in the immune system. Your immune system is constantly fighting these cancers. Right now, in our bodies, our immune systems are fighting little cancers that are appearing and disappearing because, we're good at this. But every now and again, there's a breach, there's a failure for some reason or other, and a cancer starts to grow. And 8 years later, you start to develop symptoms. So we really want to get in there. But when do we get in there? And we don't know enough about the different stages. And people have hypothesized, and a few articles have been written, surprisingly few, about how precancers turn into established cancer. Normal cells, you might get one single abnormal cell, usually it's a mutation in one gene in that cell. Then you get a stage which we call dysplasia, which no one really understands. What is dysplasia? It's basically inflammation. So you get an inflammation that gets worse and the cells become more and more abnormal, and then they switch and then they become cancerous. So where we want to go is we want to, and actually, I need to just explain another thing to you. So invasive cancer is very different to precancer. And even my colleagues, obviously not the esteemed Alan Melcher et al., but many of my colleagues think that invasive, or rather they think that precancer is basically a mini form of invasive cancer. They don't understand they're two different, completely different biological entities. And in fact, we know that precancers are reversible. Your immune system can be triggered to challenge it. And you could actually reverse a precancer back to normal without surgery, but actually using your immune system to do that. But there's a point of no return, and it's that point where you get invasive cancer. And the blood tests, the PSA tests, the CA125 tests, they work only at diagnosing invasive cancer. They miss precancer. They don't work. And so I liken this to really, if you imagine it's like a butterfly. It goes through a chrysalis phase and then becomes a butterfly, okay? Not that cancer is as lovely as a butterfly. But it really is trying to understand a different biological entity when you're talking about precancer. It's not a mini butterfly. Established cancer is different. That's the take-home message. So we want to come in with a vaccine, for example, here, before it transitions to become an irreversible cancer. And that is the focus of our work in Oxford. And we've been working for a long time with vaccines. I'm sure you remember Sarah Gilbert, who developed the COVID vaccine, which became the AstraZeneca vaccine. Very quickly, we mobilized the troops in Oxford around this issue and worked with pharma and quickly developed this vaccine that has saved millions of lives. I mean, I think it saved something like 6.3 million lives in the first year of the vaccine. So they're a bit bored now, they're twiddling their thumbs, so we've started working with them. And we're using the vaccine, the backbone of the vaccine that they developed for COVID to use against cancer, to prevent cancer. In other words, we want to go in to people who are at risk of cancer, but not necessarily have had it, and use the vaccine to see if we can reverse any precancerous lesions they may have in their bodies. And so LungVax, back to Cris Cancer. Thanks to Cris Cancer, we have been able to get off the starting blocks a year ahead of where we would have been otherwise. Because you were able to give us funding where we needed it very quickly. We had the idea, we needed to book a slot to manufacture the vaccine. You have to literally book a factory slot. It's like waiting in Sainsbury's. You know, we were right at the back of the queue, but we would have to stand in the queue for a year, but we needed the money to book the slot before we even began the research. And so the Cris Cancer money made a massive difference to us. And this is the design of the study, which we're hoping to open in a couple of years. Cancer Research UK came in after Cris Cancer, and they've also started to support it. And it helped a lot that Cris Cancer was there first, because CR UK then said, oh, by the way, we had an email today from Cris Cancer saying they wanted to support this project. I was like, oh, really? So the study is going to be in patients who've already had a little cancer resected. A long story why we need to do that, but we're going to do it in patients who've already had a non-small cell, stage 1 non-small cell resected. We know that those patients have a 30 to 40% risk of developing a new cancer, either a recurrence of their original one or a brand new cancer within 2 years, and that's because they're smokers and that other cancers are going to pop up. So we're going to trial the vaccine in the first 30 patients. We have a pause where we actually look at all the values we've got back, all the biology that we've got from that first part of the study, and make a go-no-go decision. And then at that point, we randomize to either the intervention arm where they receive the Chadox vaccine, and it's only 280 patients, versus the control. And both will get routine surveillance, so routine CT scans as they would normally get after they've had that initial operation. And at the end of that, we want to ask, does the vaccine work? But we also want to ask, how does it work? So we're doing a lot of work with our immunologists like Alan, trying to correlate the information we get from the patient's blood. So is it firing up their immune system? Which bits of their immune system? In the patients who respond, is that because they had XYZ in their blood? So it really answers important questions about how you can get the immune system to recognize when a cancer's forming. And obviously we're going to look and see who of these groups gets cancer. We desperately hope that there will be fewer cancers in the intervention group. And that will then lead to a much larger national and hopefully then international study. But we're also going to understand how lung cancer starts, and we're doing a lot of work around that as well. So this has really whetted our appetite. Now we're looking at other cancers thinking, I'd like to have a go at that one now. So the next one is Lynchvax, which is a vaccine used for people who have a hereditary mutation, which means that they get colorectal cancer. Almost 60 to 70% get colorectal cancer at some stage in their lives. And we know that at any one time, someone with Lynch syndrome has probably got some pre-cancers already in their gut. So we're doing the same thing. We've worked with the scientists in Oxford who've done some beautiful work identifying and biopsying the very, very first changes before even a pre-cancer starts, like the very first blips, and these are called aberrant crypt foci. And you have to actually spray a dye into the inside of someone's colon to see them. You spray this dye and you can see these little areas which just look microscopically abnormal. I wouldn't say that I would really notice that, but if you're one of these expert gastroenterologists, you spot that. And we've biopsied it, and it's fascinating because what we've seen is that 2 or 3, 4, 5 patients with Lynch syndrome have the same mutations, have the same changes in these aberrant crypt foci, which is weird. So even though they're different patients, have totally different lives, they are making the same changes are happening here. We call that clonality. So it's so new that it's kind of unoriginally new. And then eventually what happens is the cancer forms and it starts to gather mutations and momentum, and it's a very different beast by the time it's established. But maybe getting in here early when it's clonal is the answer. So we want to develop an off-the-shelf vaccine that we'll be able to give to people who have got Lynch syndrome to prevent them having to get colorectal cancer. So that's the next one. And then following that is another study which we're hoping to prevent breast and ovarian cancer. And there's some work going on with that. So we've got a lot of things up our sleeves. But where we're going is to rebrand cancer altogether. I think knowing, or if we did properly understand, that cancer is preceded by this early development over maybe a decade, if we start to think about it like that, and if we start to focus our energy in trying to understand those early stages, shouldn't we be rebranding cancer as a completely preventable disease? Why should we assume that cancer is just an inevitable fact of our lives? Why do we assume that it's punishment almost for our lifestyles? This was exactly the way people felt about tuberculosis. TB, they said TB was just the price you paid for poverty. We have the same excuses about lung cancer. We have the same kind of victim shaming about cancer, particularly amongst smokers. You smoked, you kind of deserve lung cancer. There's a theme. It's exactly the same as what happened with TB. And when they discovered that TB was preventable, it was a major deal. They had a lot of pushback. They had to do huge publicity to say tuberculosis is preventable. You don't have to walk into your death from tuberculosis, you can have antibiotics. And I feel like the future, I hope, is going to be that we will be saying the same thing about cancer. Cancer is preventable. And I love this idea. And where we are going in Oxford is what we ultimately want to do is develop a vaccine that we could give to everyone aged 40 to protect them from all the major cancers later in their lives. Of course, we won't give 100% protection. But can you imagine what that would be like? If at 40 years old, instead of getting your card saying, congratulations, you're going to have a smooth forehead. I think that was a Botox. You could say something like, may your birthday be as smooth as your future cancer-free life. And I really feel that that's what we need to do. So we're talking to pharma companies about partnering with us in Oxford to develop Allvax, basically a summation of all the bits of the vaccines that work in these little studies, so that we can have a vaccine that can hopefully change the way we think about cancer and turning it into something that's both predictable and preventable. So that's the plan. Thank you. Any questions?
Thank you. That was really interesting. I just wanted to ask that from what I know about cancer, it seems two people might have similar cancer, but it develops differently in their body, and everybody should have like a personalized treatment for the type of cancer they have. Do you mean to say that maybe the cancer develops differently in your body, but it begins at the same way in everybody? Is that?
Yeah, that's a really important point, which I didn't make, so thank you for raising it. So at the moment, you're reading in the press about personalised vaccines. So that's for people who've got cancer. And the idea is that you remove the cancer, you sequence it, you then give them the personalised vaccine to protect it from coming back. But we want to go one step even before that and go into people, give the vaccine to people before they even get cancer, because we think that there are similarities. So we think that it's quite clonal at that point. So maybe it only gets complicated once the cancer actually develops, but maybe there's some similarity between people brewing the same type of cancer, and that's what our data suggests so far. But I think as we get further and further into this, we'll realize, of course, there are differences. It's a bit like we're at the iPhone 1 stage, but I think that we will understand more and more nuance as we go forward.
Thank you very much for all that you guys do. I have actually two questions, and one ties into the other, but what I've heard so far is about timing, so detection. It's long before we show symptoms, so you seem to be on top of that scenario. Are we getting better at the prognosis or the cure because we're detecting earlier? That's my first question. My second question is a lot about your own immune system. If you have a very or extreme compromised immune system as an individual, are you more predisposed? So, you're going to get cancer more than somebody else would.
So, Alan, you will be able to answer the question about immunosuppression. But there is data showing that if you are significantly immunosuppressed, you are more prone to certain cancers, but not all.
Yes, no, it's curious. So, for example, if you've had a kidney transplant or a liver transplant, and you're on drugs that are needed to suppress your immune system so you don't reject your kidney, you are more likely to get some types of cancer, but not all of them. And again, I don't think we understand quite why should your, if you like, compromised immune system raise the risk of cancers 1 and 2, but not 5 and 6.
And in answer to your first question, we are, so for example, we're rolling out in the UK, it's not me personally, but we are rolling out screening for lung cancer in smokers. And that has led to already, even though it's not universally rolled out across the UK, it's being rolled out in Europe as well. But they're already seeing a massive stage shift to earlier stage cancers. So that becomes much more curable, and that affects, the outcomes. There are many cancers that are still impossible, to detect early, and they should be, in theory, like pancreatic cancer, takes 15 years to develop in our bodies, but if you get it, you know, the mortality is within 6 months often. So, my lab has been working on developing biomarkers that we could start using a bit. I was talking about this earlier. It's a bit like a cholesterol test in the future. I would love that to happen. You know, we're looking at dementia as a test that you could have. Not that I'd necessarily want to see the results of that, but you know, equally you could go in and they'd say, oh look, your cancer marker's going up a bit. You just need a vaccine. They won't even bother to look where it is. They're just going to go in straight with, you know, an all vax. And that's where I'd love it to go in the future, because we could use those biomarkers to guide the interventions. But that's still early research at the moment.
I was interested in the biomarkers, and when there was a stage in the cancer where it said no biomarkers before it becomes the butterfly.
Yeah. The chrysalis stage.
Are there just biomarkers that we're not identifying?
Exactly that.
Yeah.
And why is that? Because we've never looked for them.
Right.
Isn't that frustrating?
Yeah. And they could be different biomarkers?
Yes, they're completely different. Yeah, so people it's easy to be sort of wise after the event when the studies have failed, but people do studies looking at screening for cancer, hoping to pick up early stage cancer, using conventional biomarkers like PSA, and they're surprised when they don't yield any results because they're not actually made by the precancers. And we have to sort of really go right back and try and understand what those precancers are making, what the different biology is to them. And it seems that there are some proteins that are expressed in both. And that's kind of the area that my lab's trying to work on, is what are they, you know, and can you pick them up in the blood?